The following podcast is part of a certified educational activity titled Fine-Tuning Hypertrophic Cardiomyopathy Care in the CMI Era, Redefining Management for the Modern Heart Failure Specialist. Access the entire activity and complete the post-test at peerview.com/RJP860. Downloadable slides and practice aids are also available.
Good evening, and thank you very much for joining, and welcome to the attendees here in person, as well as those of whom you are joining us virtually. This CME activity is prepared a lot by PeerView, and we are going to have a discussion about how to fine-tune HCM care in the current era of cardiac myosin inhibitors. How do we define and redefine modern management of HCM, especially for the heart failure specialist? I'm Milind Desai from the Cleveland Clinic, and with me is my very close friend, Dr. Anjali Owens from University of Pennsylvania. What do we plan to achieve today? Recognition of HCM, especially obstructive HCM, is crucial. It needs to be done early, and separating it from the phenocopies and different phenotypes. Where are we in terms of guideline-based obstructive HCM management, and how do they incorporate novel way of thinking, including therapies? CMIs, cardiac myosin inhibitors, they offer a disease-modifying treatment option, which we will discuss in-depth data as well as the clinical real-world application. And how do you incorporate shared decision-making, personalized treatment plans, et cetera, and follow-up monitoring. So before we go there, we have to go here, right? We have to get it right from the get-go. Again, I'm Milind Desai. Imaging is my background, so HCM is the best disease which lends itself well for a perfect cardiovascular imager. Why is that? First is you have to identify the appropriate phenotype, identify the anatomy. The classic definition is LV wall thickness more than 15 millimeters or 13 millimeters in individuals with a family history. This may or may not be in conjunction with a positive genetic test, and the patients follow a full spectrum. Patients don't read a textbook. They do not have pictures drawn by graphic designers, so there may be some overlap, but you have to identify the spectrum from normal to obstructive, non-obstructive, mid-cavitary obstruction, apical variant. And a progression may happen. To make things more complicated, we are entering into the era of artificial intelligence and machine learning and potentially redefining what it means to be called an HCM patient, okay? Because there's variation based on age, sex, body surface area, et cetera. This is an equal opportunity offender, okay? It affects all sexes, all races, and all ages in all places. It is not rare, but certainly a lot clinically underdiagnosed. The prevalence is thought to be around between 1 in 200 and 1 in 500. And the median age is about 46 years. So for a genetic disease, if the median age is 46 years, it begets the question, what the heck are we doing for those first 45 years and 11 months? 2 cases are missed for everyone is diagnosed. And in the United States, there's about 700,000 patients. The world has, 8 billion people? Do the math. That's a lot of patients. And there is a significant amount of disparity in care based on where you live, what your insurance status is, hospital not-for-profit status, et cetera, et cetera. When should I suspect HCM? Of course, if you have symptoms, okay, dyspnea, dizziness, syncope, chest discomfort, palpitations, and symptoms can vary from day to day. Family history, cardiac exam, systolic murmur that increases with Valsalva maneuver, abnormal ECG, arrhythmias. Unfortunate reality is a lot of times before the right diagnosis is made, you often get a wrong diagnosis. The 3 most common are what? Benign murmur, asthma, and crazy. before a real diagnosis is made. True story.
Which are not mutually exclusive.
Yeah, and which are not mutually exclusive, but you know, yeah. So you have to have a broad differential diagnosis and thinking process. This is something we just recently published less than a month ago. Natural history of asymptomatic HCM patients. 3,393 patients seen at the Cleveland Clinic, all confirmed to be NYHA class 1, confirmed and reconfirmed. About 40% were obstructive, the rest were non-obstructive. 61% had a diagnosis of hypertension, okay? 19% during the long-term follow-up progressed to NYHA class 2, 8% class 3, and 1% to class 4. And they were appropriately well treated. Okay, this is data on the obstructive population. What we saw compared to a gender-matched normal population and non-obstructive patients, the obstructive patients did far worse. So it is absolutely incumbent upon us to identify HCM, but also identify the obstructive phenotype, because that is where disease-modifying therapy is absolutely helpful, beneficial. Lots of data we will talk about. How do you diagnose? Based on the recent guidelines, basically beyond the ECG and history taking, transthoracic echocardiography is the primary modality for diagnosis, helps you characterize not only wall thickness, mass, but outflow tract obstruction, and it is used for screening and follow-up. CMR is complementary to cardiac echocardiography and used especially if TTE is inconclusive. Additionally, it helps identify myocardial fibrosis and diffuse fibrosis, etc. TE is generally used as a secondary adjunct during procedural scenarios. Scintigraphy, so technetium pyrophosphate scanning has come to the forefront now for identifying phenocopies. It is absolutely step one. Once you make the diagnosis of HCM, it is important to distinguish between obstructive and non-obstructive phenotype, because for sure, the long-term outcomes of obstructive phenotype are worse, and we have highly effective medical and invasive therapies. Beyond which, it is also important to distinguish between HFpEF, heart failure, preserved ejection fraction, as well as things that look like HCM. We are entering the brave new world of artificial intelligence that is helping us not so intelligent and intelligent human beings in making the diagnosis of HCM. This is one such program from Viz AI, which is FDA approved to detect HCM. We have validated this data, and even at main campus Cleveland Clinic, in the first 6 months of us incorporating this algorithm, we found 50 patients without a diagnosis of HCM that were eventually found to be HCM floating in the system. So it does help increase your diagnostic confidence. AI is also improving point-of-care ultrasonography. This is data from Yale New Haven that was again recently published. In more than 290,000 standard echoes, basically diagnostic ability area under the curve for HCM was 0.90 on a single apical 4-chamber view. Okay? So this has the potential of being scalable and a game changer for reducing the rate of underdiagnosis and misdiagnosis. Let us talk about Catherine, this young patient aged 54-year-old, presenting for a well-woman examination. Hypertensive, occasional alcohol use, no family history. Blood pressure is relatively okay. Heart rate is within normal limits. Body mass index, she's doing well, 25. Everything else, laboratory evaluation was unremarkable. And she's on metoprolol, succinate, and occasional naproxen use. Probably she has teenagers at home. She complains symptoms that are consistent with PVCs, which increase with increasing fatigue over the last year, and baseline ECG performed that was suspicious for LVH, and patient ECG suggests this. That's not suspicious. That's grossly positive for LVH with major strain pattern, right? So obviously the next thing we did, or this patient underwent, was a transthoracic echocardiogram to look for structural heart disease. So not all LVH is HCM. And the older you get, the wider your differential diagnosis. You've got to contend with hypertensive heart, aortic stenosis, HCM, athlete's heart, amyloid, other diseases like mitochondrial Fabry's disease, Pompe's, Dannon's. So you have to have a broad differential. Patient's echocardiogram in your laboratory does not come with, this is a patient of Pompe's disease. You are lucky. It's mostly, this person has a thick heart. Figure it out. So, Catherine's baseline echo data at rest on the right shows what? There's some degree of SAM and some degree of basal septal hypertrophy. If you look at the images on the right, there's a fair bit of SAM, now contact SAM, with turbulence in the outflow tract and a posteriorly directed jet of MR. So, what is everybody thinking? Basal septal hypertrophy, SAM, posteriorly directed jet of MR. Gradients at rest and with Valsalva, basically there is significant LV-OT obstruction. This patient has gradients in the severely obstructive category, right? 2.1 centimeter basal wall thickness, 65% EF, SAM, all the happy stuff. So patient is diagnosed with obstructive HCM. So with that, we have to follow the evidence, and it is my privilege to introduce Dr. Owens, my very good friend, who will walk you through the data.
Excellent. Good evening, everybody. So we'll talk a little bit about the long-term, both clinical trial and real-world experience with cardiac myosin inhibitors and how this is reshaping our care. So let's think about the history of pharmacologic therapy for hypertrophic cardiomyopathy. And prior to 2023, we really had agents that were repurposed from other conditions and other indications and used for HCM with the thought that they would improve diastolic function, slow down the heart rate. These are, of course, AV nodal blockers, beta blockers, and calcium channel blockers. We also then use a negative inotropic agent that is an antiarrhythmic, disopyramide, later in our experience. But these studies really did not have large, randomized, placebo-controlled data behind them. These were single centers and essentially anecdotal experience for much of the data behind these agents. And we know that they were not designed, nor do they target, the underlying disease process in HCM. And so, what eventually happened is that we did come to understand the underlying disease process and targeted drugs and developed drugs to treat that disease process. And of course, that happened with the first cardiac myosin inhibitor, mavacamten, first in class, which was approved in 2022 by the FDA and subsequently incorporated into both the 2023 ESC HCM guidelines and the 2024 AHA-ACC guidelines. So what are these agents, this new class of medications, the cardiac myosin inhibitors? Number one, they're cardiac specific, so they don't affect your skeletal muscle. And number two, they're reversible, so their effects will go away if you stop the drug. They're not irreversible. And they really were formulated on the basis of targeting hypercontractility, which is part of the pathophysiology that we see in hypertrophic cardiomyopathy. These are hearts that tend to be hyperdynamic, energy inefficient. And so by relaxing them and stabilizing the myosin relaxed state, that reduces the number of interactions between actin and myosin at the level of the sarcomere. So you're taking a heart that's hypercontractile and making it squeeze and relax more normally. Of course, that means that if you get too much of one of these medications, your heart could become hypocontractile, and so you're really targeting and modulating contractility with this class of drugs, which was new. First-in-class agent, as I mentioned, is mavacamten, and the next-in-class agent is aficamten. So we'll talk about data for both of those agents. And here's where we are with clinical trials. So the first pivotal phase 3 trial for mavacamten was the EXPLORER trial that led to FDA approval. The MAVA long-term extension, or MAVA-LTE, was those patients from EXPLORER who joined an open label extension trial. The second phase 3 for mavacamten was the VALOR trial. This, of course, was sicker patients. Over 90% were class 3 at the time of enrollment, and all of them were actively considering septal reduction therapy. So a sicker population than the EXPLORER group. And they were on maximally tolerated medical therapy that included both beta blockers, calcium blockers, disopyramide, and any combination of those agents. Next, we have the trials that were done for aficamten. So the first phase 3 is the SEQUOIA trial, looking at aficamten versus placebo. That read out just in the last year. And now we have the MAPLE phase 3 trial, which was aficamten head-to-head against metoprolol. So going back to our historical days of not having RCTs of metoprolol, we now have one head-to-head against aficamten. That was presented just a few weeks ago in Spain, and we'll go through that data. Patients from the aficamten program are now enrolled into the FOREST-HCM open label extension, and we'll go through some of that data. So first, let's start with the mavacamten open label extension. These are patients from EXPLORER out to 3.5 years. So what happens in the long run? Is this effect of cardiac myosin inhibition sustainable? Is it durable? And what does it look like from a safety standpoint as well? So these are patients that you can see out to week 180 with resting LVOT gradients at the top, Valsalva gradients at the bottom, that started off obstructed and then had a decline in their gradients by 40 millimeters of mercury at rest, by over 50 millimeters of mercury with Valsalva. And again, these are levels of gradient reduction that we do not see with AV nodal blockers or even disopyramide. Diso does better than the AV nodal blockers, but not to this extent. These are surgical level resolution and improvement of gradients. NT-proBNP came down, quality of life came up. Left ventricular ejection fraction in this series was down about 9 or 10% over the time frame. And this is something to consider because, again, we're modulating contractility. And we need to understand in the long run how best to do that. And I would submit to you that's still probably an unanswered question. We did see that 80% or so of patients, nearly 80%, improved by one NYHA class or more. And it's important to note that in aggregate, the mean LVEF remained normal. But within that, there's individuals who could transiently go below our threshold of 50%, in which case you need to temporarily stop the drug, readjust your dose as the LVEF comes back up. So let's look at remodeling. This is really important because we know from data from mavacamten that yes, absolutely, gradients are going to come down. Patients are going to improve in functional class, in objective exercise tolerance, in their patient-reported outcomes. But what's going to happen to their heart over time? Are we going to be able to change the trajectory of disease and modify disease in the long run? And that's obviously a very important question because it gets at disease modification and also tells us whether or not we should be starting earlier. If we're able to change the trajectory, that opens up the avenue to say, if we start earlier, will we get more benefit? So looking here at the data from remodeling, you can see mass index comes down, left atrial volume index comes down substantially, wall thickness comes down. So the hallmark of HCM, of course, is left ventricular hypertrophy, and we're starting to see regression of hypertrophy, improvement in mass, improvement in left atrial volume index. Let's look at freedom from septal reduction therapy, another important long-term aspect of disease. Are we taking these patients and temporarily relieving the need for septal reduction therapy, or is this going to be a durable response and patients are able to avoid open heart surgery or alcohol ablation in the long run. So this is very important data from VALOR that was published very recently, looking at 128 weeks after starting the VALOR trial. And remember, this was a crossover design. So placebo group received placebo for 16 weeks and then crossed over to mavacamten. So you'll see on the graphs on the right, at 16 weeks, the orange line, which is placebo to mavacamten, starts active drug, and the dark blue line started mavacamten from the beginning of the blinded portion of the trial. And what we found is, yes, these are very durable results, not only with NYHA class improvement, but with biomarker improvement, improvement in quality of life, and not pictured here, improvement in gradients. So these are durable results. What else did the echoes show us from VALOR? Again, getting back to that question on disease modification. These were sicker patients who may have come in with a longer duration of disease, more severe disease. Was mavacamten able to impact those hearts? And what you can see here are the total sample, both in blue and purple at the top, that there was improvement in left atrial volume index, an improvement in strain. That's really important, without negatively impacting the RV, which again, we'd like to step back and look at the whole heart and see where is this patient going in the long run. Also, 2 subgroups were looked at that are important subgroups in HCM. About 30% of our patients have a history of atrial fibrillation and a high incidence over time if you remain obstructed with HCM. And so we saw no worsening of strain in that population. And we also wanted to look at the subgroup of patients who dropped their ejection fraction to less than 50%. Although this is a small number, it's important to look at them and see what were their outcomes. And what we saw was no worsening of strain in that group. Here's a more pooled safety data. These are pooled from 5 trials of mavacamten over time, presented in abstract form last year. And what we saw that was important is that over time, the AEs of clinical interest, which include AFib, ejection fraction decreased, and heart failure, got less and less over time. So are they zero? No. But they're definitely better as time goes on. And again, this is data to help us to understand what's going to happen to these patients in the long run. So if you are using mavacamten and you see that your patient has a history of paroxysmal AFib and you start them on the drug, it's possible that they're going to have paroxysms of AFib. But what we would hope is that if you start to get those beneficial remodeling effects, left atrial volume starts to shrink, obstruction resolves, left ventricular hypertrophy is regressing, that over time you would see less atrial fibrillation. And again, we need longer term data, but this is out to year 5. So let's switch and look at the next in class agent, which is aficamten. And you'll recall our clinical trial slide. This is data from FOREST-HCM. These are patients who were in a parent study of aficamten who have rolled over to open label extension. This is at 48 weeks. We know the development plan for aficamten was later than mavacamten, so this is the data that we have at 48 weeks. And you'll see, again, gradient reduction, 40 millimeters of mercury at rest, over 50 millimeters of mercury with Valsalva, improvement of NT-proBNP down by over 60%, and a small drop in ejection fraction that again is by mechanism of action expected, in this case about 5%, and about 80% of patients who improved their NYHA functional class. So now let's look at MAPLE. This is the latest phase 3 trial that we have in this space, cardiac myosin inhibitors for obstructive HCM. And this was the first head-to-head trial of aficamten versus metoprolol. So cardiac myosin inhibitor versus what's currently first-line therapy by the guidelines, metoprolol, or a beta blocker. So what was the aim of this study was to look at peak VO2. That was the primary endpoint here, assessed by CPET, baseline to week 24. There was a host of secondary endpoints that included NYHA functional class, our standard PROs, biomarkers, remodeling. This was 24 weeks of treatment, echocardiography used to dose aficamten, and vital signs used to titrate beta blocker. That's important, and we may get to it in the discussion. So here are the results of the primary endpoint. peak VO2 on the left and the least squared mean difference on the right. And at baseline, you can see that the peak VO2 is in the 19 to 20 mils per kg per minute range, so a little less sick population than, for example, SEQUOIA. And what you saw at week 24 is that the metoprolol patients actually got worse on their peak VO2. And I'm at a heart failure conference, so I don't need to explain to heart failure doctors that beta blockers can reduce your peak VO2. This was not yet studied in an obstructive HCM population, and now we have the data to show that. In the aficamten group, you can see a nice rise in peak VO2 by about 1 mil per kg per minute and about 1 mil per kg per minute that went down in the metoprolol, leaving a least squared mean difference of about 2 with a very significant p-value. When we looked at NYHA functional class, again, you can see that more patients achieved NYHA functional class 1 in the aficamten group at week 24 in the light blue than did in the metoprolol group in the light orange. And the NT-proBNP, the metoprolol group, again, got a little bit worse in their NT-proBNP, and hopefully we'll have some time to discuss those findings, versus aficamten, where we had a pretty prompt and significant decrease in NT-proBNP. What did we see in terms of gradients, and what did we see in terms of left atrial volume? So as expected, and has been shown in the prior phase 3 trial of aficamten, it resulted in decrease significantly of both resting and Valsalva LVOT gradients. They're in blue over the 20-week period. Those changes are reversible during the washout. And metoprolol, lo and behold, really no change in the gradients, as you can see here. Now, many of us that treat patients and have treated patients for years with metoprolol did scratch our heads a little bit on this, because I don't think we felt that metoprolol was a game changer, but I definitely have seen patients where their gradients improve. So I don't know that I could explain this, but the data is the data, and this is what we saw in a randomized placebo-controlled trial. What about safety with regard to the MAPLE data? Pretty equal between aficamten and metoprolol. However, there were patients in the metoprolol group more than those in the aficamten group, which is the last line there, that led to dose reduction. And again, this was titrated based on heart rate and blood pressure. So if you got hypotensive or bradycardic, that you limited or went down on your beta blocker. There was one patient in the aficamten group who had an LVEF less than 50%. That occurred in none of the patients in the placebo group. And the percent of LVEF drop was about 4% at week 24 in the aficamten group. So what do we know about mavacamten monotherapy? I've just shown you slides from a phase 3 trial on aficamten monotherapy. What about mavacamten monotherapy? Well, we don't have the exact same trial design that's been done with mavacamten. We have a smaller analysis that was presented again just recently at ESC by Jacopo Olivoto, looking at the patients within the trials who were not on background therapy. So they were essentially mavacamten monotherapy with a small n there of 9, or placebo monotherapy. And we saw with mavacamten monotherapy in the top graph a similar reduction in LVOT gradient and a similar improvement in NYHA functional class. So we're extrapolating a bit here. It's not the same trial, but this is the data that we have to date from mavacamten. So we're now going to talk about rewriting the playbook. How do you approach HCM in the real world?
Yep. So, to that previous question, majority, or we are finding a lot of patients, they say, let me try medical therapy. If that doesn't work, it's hard to go back from a septal myectomy. It's hard to do a myectomy, hard to undo a myectomy scar, right? So most people will agree. So let's see where we are. You know, based on the plethora of phase 3 data, 60 years, there's all the guidelines talk about is consensus opinions and expert opinions. Now we cannot spend a month without having a new phase 3 trial introduced in this, so which is good, renaissance age for HCM. So what do the ACCHA guidelines say? Beta blockers or non-dihydropyridine calcium blockers, try them as first line. If symptoms persist, then you have myosin inhibitor, diso, septal reduction therapy. I don't know, Anjali, about your practice, but in my practice, we are not that heavy, if at all, on diso. So I don't know how we get the same level of indication here, but we can talk about it. I reserve diso for my mother-in-law. No, I was not gonna bring that up, no. Anyway, download the treatment practice aid for further details about the guidelines, et cetera. So mavacamten was approved in April 2022 under the risk evaluation mitigation strategy mandated by the FDA because of potential concerns related to LV ejection fraction reduction. This is a cardiac myosin inhibitor. It is going to inhibit the cardiac myosin. And part of the deal there is you may have some patients with EF reduction. The other thing, and so do not initiate under 55%, interrupt if less than 50%, or if you have heart failure symptoms or worsening status. The other situation is around drug-drug interaction. This is excreted through the cytochrome P450 system, and you have to worry about these interactions. Thankfully, we have fantastic pharmacists and all these electronic things that flag you so that, it's become less of a novelty now, especially for us who practice in this space. Bottom line is you gotta check medication list at every visit, review DDIs, and there's gonna be a few people where you may have to switch. In my practice, the most common thing is a proton pump inhibitor, switch from Pepcid to some other SID. Omeprazole to lansoprazole is the most common thing I end up doing. Everybody needs to be on the same page. The patient, the provider, the pharmacist, the patient's relative if the patient is not very reliable. Training is required, clearly. But for every perceived inconvenience, the flip side of that is what? An opportunity. Okay? So now we have the world's largest obstructive HCM database with detailed serial follow-up echoes prospectively collected. Tell me which other disease has this. Okay? So we have taken advantage of this. This is data from the first 22 months of the REMS program. How is this drug doing in the real world? Okay? More than 6,000 patients, of which 5,573 were included in this analysis, 29,000 forms filled. Every time there's an echo done, there's a form filled and entered on the website. What did we find? Less than 5% EF of less than 50%, okay? Out of the 29,000 forms, less than 1%, 0.9% to be precise, with EF less than 50%. Heart failure hospitalization, 1.3% patients, 0.3% patient status forms associated with that, okay? And so on and so forth. So bottom line is, in the real world, in fact, I would like to venture out and say in the real world, the drug is performing better in terms of side effect profile, EF reduction business, compared to what we saw in the clinical trials, because here we are having the added human touch, the clinician touch to the management. 52,000 drug interaction checklists performed, 0.25% reduction in mavacamten dose, and 0.32% discontinuation of concurrent medication. So again, the system works. What does it do to the gradients? Now, similar to the clinical trials, it is showing very similar efficacy in terms of Valsalva gradients. In fact, there were about 700 patients where after first dispense, the gradient reduced to less than 20 millimeters of mercury, to a point where we would be confident enough to even lower the dose. Drug-drug interaction, again, I'm not going to belabor the point. It is contraindicated in some CYP450 inhibitors and inducers. More relevant contraindication, ritonavir, omeprazole, fluoxetine, fluoxamine, fluconazole. Okay? Dose adjustments are needed with amiodarone. If you are into recreational entertainment for yourself, marijuana, alcohol, you may need to adjust the dose. Bottom line is multidisciplinary collaboration is important and has been highly successfully implemented in clinical practice to a point where we don't, I don't lose a sweat. It's not a novelty. Now it's just one prescription and life goes on and things fall into place. Please download the DDI Practice Aid. This is something we just presented at ESC and simultaneously published. This is our first 244 patients, of which 171 got at least 1 year of mavacamten. These are all Cleveland Clinic patients. To be included, they had to be prescribed for at least 3 months, so stable dose. Mean age slightly higher than the trials, 51% NYHA class 3 at entry. We initiated on 5 milligrams a dose, and similar to what the REMS program in the clinical trial. Data, very, very good, very similar improvement in NYHA class. EF stayed within normal limits, but reduced as expected gradients. Additionally, this paper also showed strain, LA volume index, diastolic function, everything improved in this obviously open label real world data. More importantly, one patient has undergone cardiac surgery. This is at the Cleveland Clinic. Okay? So everybody was offered shared decision making to go choose whatever was available. One of these patients has undergone cardiac surgery and 0 alcohol septal ablation. So Catherine, yes.
Do you guys remember Catherine?
Yes.
Do you remember?
Do you remember? I hope you remember.
From the beginning.
So newly diagnosed obstructive HCM confirmed on echo, currently treated with metoprolol, succinate, and occasional naproxen use. Following a case conference, Catherine is determined to candidate for CMI, REMS enrollment. 4 weeks gradient is 40 millimeters, 8 weeks 35 Valsalva, 12 weeks in the non-obstructive arena. EF is preserved, and the plan is to continue mavacamten dose at the current level. For those of you who are interested, you can download the practice aid. So to summarize, I think we are doing really well on time. We want to have some time for Q&A. HCM is an equal opportunity offender, okay? And asymptomatic on time point A doesn't mean that they will be asymptomatic at time point B and C. You have to be diligent about taking history and provoke symptoms, not just gradients, provoke symptoms. Multimodality imaging is key to diagnosing, staging, and managing HCM. CMIs are first targeted precision therapies for obstructive HCM. MAVA was approved in 2022, and we have extremely favorable results through the REMS program. Aficamten PDUFA date is set for day after Christmas, is what I understand. And as I alluded to, real-world long-term experience with this class of drug, mavacamten, has been positive with efficacy, safety, and outcomes very comparable or superior, dare I say, than clinical trials. So it's time to discuss questions.
Good. We've got a few coming in. I'll read the first one as other people put their additional questions in. So the first is, patient clinically improved on a cardiac myosin inhibitor. Gradient remains 40. When would you increase the dose if the patient has improved on present therapy with a gradient above 30? The patient does remain on a beta blocker, and the LVEF is 60. What would be your approach there, Milind?
Yeah, I think, again, I would have a discussion with the patient, see how they're doing, at this based on the algorithm, it would be appropriate to increase the dose to 10. But often, in my practice, I would end up seeing a patient whose starting gradient is 100 millimeters. Now it is 41, and they're feeling like $1 million. I may choose to be careful with them, especially if they're, So a lot of clinical decision making goes into these things. But yes, that's how. And the other thing I would do in this situation is I would definitely be tempted, not tempted, I would definitely down titrate the beta blocker, because sometimes you never know where the symptoms are coming from. That fatigue could be the beta blocker. So what do you think?
Yeah, I agree. And I think it really gets to an open question, which is, are we looking for maximally tolerated dose or minimally effective dose with this class of drugs? And because they're new and we don't yet have long-term data, as we alluded to, on disease modification, hard outcomes that we like to see in cardiology, like sudden cardiac death, risk mitigation, or mortality, that we're really left with the conundrum of, do we titrate up to maximally tolerated, like we do for GDMT for HFrEF, for example, or are we just looking for the minimally effective dose? And this question has come up when we think about these drugs for non-obstructive HCM. And so I would say sometimes perfect is the enemy of good. And if you have a patient who's class 1, doing very well, biomarkers have nearly normalized, and they have a peak gradient of 40 at 10 mets on a treadmill, I'm not pushing the dose in those patients. If there's residual symptoms and their LVEF is in a safe range, then I would go up. And I completely agree with Milind. I think the next frontier is, what do we do with background therapies? Now that we have had a head-to-head trial of aficamten versus metoprolol, but can we extrapolate that data and say, what do we do with beta blockers and calcium blockers? And most of our patients come in asking to down titrate their AV nodal blockers or go off. And so we are doing that in the vast majority of our patients.
I have a question.
Sure, you're not on the line, but go ahead.
I'm cutting line, come on. So we both brought up the beta blocker trial data. So what are your thoughts about in a 24-week trial, okay, the peak VO2 going down in the beta blocker, possibly expect. But if you do the back of the envelope calculation, the BNP in a 24-week trial, it went up, it got worse by almost 30 or 40%. Have you seen that in clinical practice? And what are your thoughts about it? Is that because of potentially over beta blockade?
Yeah, I think that's what we're looking at. So the highest dose of metoprolol in MAPLE was up to 200 milligrams. And we know that over 50 to 60% got to the two highest doses, 150 or 200 milligrams of toprol, which is a lot of beta blocker. And when you titrate quickly, as we know in the heart failure realm on beta blocker, you got to be careful. And so I do think that part of what we saw over those 24 weeks was a relatively rapid up titration of beta blocker. I mean, we know from the placebo-controlled trials, SEQUOIA, EXPLORER, VALOR, that typically what we see on that time frame, someone coming in already on a stable dose of beta blocker, is no real change over a year in peak VO2, right? This isn't amyloid where people are getting that much worse over a year. So I think it is reflective of the titration scheme for beta blocker, and it probably tells us in the real world, like, don't do that to your patient. There's no need to go up to that high dose of beta blocker when you have an alternative targeted agent that's going to give you plenty of efficacy without the potential downside of worsening peak VO2, worsening biomarkers, worsening left atrial size.
Unless they're from your outlaw side, in-law side or no.
So,
okay.
Yeah. Okay, another question from the audience. There's a 1-year wait to obtain cardiac MRI in Toronto. Can they be ordered in the USA? How much do they cost? I'm going to give this to the multimodality imager. He might have a heart attack on the stage.
No, I'm the Heart Vascular Thoracic Institute Cleveland Clinic's Director of Cardiac MRI. So look, MRI is a very useful adjunct to echocardiography, okay? For risk stratification, for predominantly confirming what you see in terms of wall thickness and all those things on echo, okay? Additionally, you get multi-parametric imaging for late gadolinium enhancement, scar assessment, fibrosis quantification, for deciding about what? Primary prevention ICD, okay? In my 20 plus years of practice, I have yet to see a patient who died because they did not get a cardiac MRI, okay? Let's just be clear about that. It is an adjunctive complementary test, okay? there goes my invitation to SCMR.
You're done. Here's a really good question. Let's move to this.
So the waiting period, yes. Okay, this is a story everywhere. Okay, because MRI, you can do 8 or 9 or 10 per day per machine, and we don't have machines lying around like echocardiography. So it is appropriate, judicious use of technology in the rightly selected patient. And yeah.
So back to CMI, how often do you get an echo once you start a cardiac myosin inhibitor? What's the treatment algorithm there?
So again, most of you will have this as part of the REMS program. You need the baseline, obviously, then once a week, 4, 8, 12 weeks. And then before, when the original REMS program came out, then if you are at a stable state, you get it every 3 monthly. But now, since April or thereabouts, it has, because of the highly favorable REMS data that I've shared, now you get it on a stable dose once every 6 months. And that's, if you adjust the dose, then you basically have to go back and restart. Now, the other thing is, if you have EF drop, then you need to lower the dose and recheck in about a month. Okay, if you have, look, in real life, the way I look at it is, if your patient, if you are this is assuming the patient is doing well and nothing else is going on. If your patient appears to be in heart failure, if the patient has gone into rapid AFib, any of this thing, it's only an echo. Yeah, get it.
And the only other caveat to the every Q6 month echoes is if your patient is in that range where they have a lower EF, they're in between the 50 to 55 range, that's a population where they are at risk to drop because they're very close. And so in those patients, you can continue every 3-month echoes. Next question here. Let's see what we've got. What is your experience in terms of insurance coverage? What's been your real world experience?
So, and again, I want to hear your perspective. Also, we both practice in different states. So far, it has not been a barrier. Working with the company, and they have put in multiple programs in place, but vast majority of the insurance companies understand CMIs. They want to see first-line therapy being instituted. Most of them are okay if we say they are on a beta blocker and then, initiate mavacamten with appropriate approvals. There are some who say, no, you try this, you try that. Often you get faced with beta blocker intolerance and they say, no, you have to try something else before you go on mavacamten. But so far, I hate to say this, but I have had only one patient where it was a hard stop and he was a Cleveland Clinic employee. I kid you not.
The ultimate in irony. No, I think our experience is similar. It's not a drug that you simply prescribe and then completely walk away. This is a team approach. So you have your pharmacists, you have your nurses, your NPs, and you get the patient access to the drug. Now, in the heart failure world, that's not foreign to us. There are many drugs where we have to use them and use them carefully in conjunction with the team. And I would say that's very similar to our experience for myosin inhibitors. But in most of our patients, we haven't had costs as being a prohibitive issue. We have seen a slight difference between the commercially insured versus our Medicare population. It takes a little more finagling, grant support, timing, et cetera, to get our Medicare patients on, but we've been able to do it successfully, and that no longer is seen as a barrier, at least in our clinic.
So assume you're Yogi Berra and you can predict the future. How do you foresee this playing out, say, tomorrow or Wednesday, your clinic? I know you have clinic on Wednesday. You go there and your patient walks in there and said, Doc, why the heck are you poisoning me with this metoprolol succinate? Why can I not just be on this CMI as first-line therapy based on the most recent data? Are you not up to date with medical literature.
Right. Yeah, I think we're going to start to get those questions, quite honestly, and we are all going to highly anticipate what the guideline writers are going to put together in their update. And, quite frankly, I don't know. I think we also have to contend with implementation and cost on a wider scale. We'd be silly to think that those aren't important issues. But I think the patient will have a point. Right? If they're having side effects, not well tolerating, why would you do this and not switch to something else? So I think it's a valid point. Another question here. If the patient has shown positive cardiac remodeling and for whatever reason stops CMI therapy, does the remodeling reverse after the washout?
This is an interesting question. And I've often, I was abroad, and this same almost exact question came up. And so as of right now, what we know is if you stop the drug, the gradients definitely come back, okay? Now, could we be living in a time in the future where you have marinated the myocardium enough for many years that the wall has gotten significantly thinner, mass has gotten significantly more towards the normal, LA volume index has gotten significantly regressed, strain has significantly improved over a period of a few years where the internal milieu of the heart has changed enough where the changes are longer lasting. I don't know the answer to that. Hard to predict, especially the future, right? So, but it does make intuitive sense. Now, if the gradient comes back in its full glory, and then, you wait 2 more years untreated, then all those things, would they come back? All the badness comes back? Hard, probably, but hard to know.
Yeah, and I think, to follow along those lines, another question that I find myself asking when we see our patients from the MAVA-LTE trial in particular, 5 years out or so, is whether or not they need as much myosin inhibition. Not so much a question of whether you stop it altogether and remodeling comes back, but whether there is maybe a maintenance phase dose that doesn't require as much myosin inhibition, and that may level off if you're still seeing very slight declines in ejection fraction, that may level it off. And so those are unanswered questions that I think over time and additional use we'll be able to answer. All right, let's see. Is there any questions live in the audience here? If not, we'll see if there's a couple more here. Yes.
I've got a question for you speaking about long-term changes. Do you ever reduce the dose, thinking about patients who are on the maintenance phase and who might not need?
I have. Personally, yes, I have, but it's not in an algorithm. This is where the science is lacking. It becomes more of an art than a science. So yes, I have. In certain patients where I've seen that remodeling, their EKG is normalized, their ejection fraction maybe is in the high 50s now, and I feel like they don't need as much. I have.
There's two, actually, you bring up a couple of points that I'm going to make. One is, I wholeheartedly agree with Anjali, and I'm not going to belabor that same point, but there's 2 additional things. We are very aggressive, and I know you are too, about reducing the background therapy significantly, aggressively if they continue to do well. But there's another thing that we are doing in earnest. I showed you even the asymptomatic folks. A lot of those folks have hypertension. And what is the JNC guideline treatment for hypertension? Losartan, amlodipine, all those penes, right? Which are typically not indicated in obstructive HCM. So what has CMI therapy allowed us to do? You quickly make these patients non-obstructive. Now you can go at it for their hypertensive therapy with whatever you want to use. So, 5 years from now, you may have patients who are feeling better from CMI, who have all the good remodeling from all the established antihypertensive therapy, plus the remodeling from the CMI therapy. So we may be living in a fortuitous world where there's improvement all around, hopefully.
And in a subset of patients, as we relieve their obstruction, we do see hypertension. which makes sense in terms of increasing forward flow cardiac output. And in those patients, then you're able to use whatever you want, which we typically use angiotensin receptor blockers and maybe an MRA. Another question, and then this will probably be our last one.
Sure. Very interesting presentation, very well done, to explain to us. My question is regarding gender impact. Young women comparing to older women, menopausal or post-child delivery, or men at different ages. Did you have any information regarding gender impact or age or BMI as well?
Yeah, great question. So in the sub-analysis that have been done on gender from both Explorer and VALOR, there have not been any significant differences in efficacy and safety. What I will say, though, is mavacamten is contraindicated in pregnancy. So if you have a woman of childbearing age, that is a very important thing to discuss with them up front. And whether or not, if they want to carry a pregnancy, whether they may be better served by a myectomy, durable relief of obstruction, and then carrying the pregnancy, which is what we typically recommend to our young women. Or they have to be on birth control and they have to be careful about not getting pregnant. So that's always important. BMI data I find fascinating. I don't know what you think, Milind. Anecdotally, maybe the larger patients need a little more, as might be the case for other diseases and meds as well. I do worry a little bit about the women who start maybe in a later stage of disease. We know this from just natural history data in HCM, that the women tend to present later on, have more heart failure, probably because of our one-size-fits-all approach on diagnosis by hypertrophy thresholds that are not indexed for body size. So by the time a woman reaches 1.8 centimeters or 2 centimeters, they're way far along compared to a man who may be larger. So I think once we move to a more sophisticated approach of making a diagnosis that's more personalized to the threshold of pathologic hypertrophy, maybe we would see some of those dissipate those disparities.
And that's what I alluded to earlier in my imaging presentation, that we are quickly reaching where we have to learn to index everything. The things are not the same for LeBron James as for, whatever that gymnast is. You gotta treat, both of them are world-class athletes, simple as that. And the other thing pertaining, I'm venturing into the OB world at my own peril, but I'll give you an anecdote or two, literally, just recent one. Real life patient, somebody who I took care of right after MAVA came, and young woman in college, and she goes, I'm on birth control. I do not have time to go through a 6-week recovery, myectomy, all that happy stuff. I want mavacamten. Are you sure? Yes. So mavacamten for 3 years. And then now she got married, she wants to start a family, comes back, stop the MAVA for a year, for a month, let it wash out. She has a myectomy, now she can have the rest of her family life. So it's not this or that, it's always how do you take care of the patient in that moment in the best way possible. Thank you very much. Thanks a lot.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through an educational grant from Bristol Myers Squibb. To access all materials for this activity, visit peerview.com/RJP860.